Well, good evening, ambassadors and friends of the James. I'm James Foundation board member and co-chair of the James Ambassador Society, Scott McComb. Thank you for your commitment to learning more and advocating about the work happening at the Ohio State Wexner Medical Center and the James Cancer Hospital and Solov Research Institute. If you have any questions throughout the session, please use the Q&A feature at the conclusion of the panel discussion, and we will answer those questions if we have time. I'm sure the doctors have lots of riveting comments that we're going to be listening to this evening. Tonight, we'll be hearing from a team of surgeon scientists that specialize in diagnosing, determining the stage of cancer and or removing cancerous growths. It is my pleasure to welcome Director of the Division of Surgical Oncology and the holder of the John R. Maracus Nationwide Insurance Enterprise Foundation Chair in Cancer Research, Dr. Alan Sung. Doctor, take it away.
Thank you, Scott. Well, good evening, everyone. It's really a privilege and an honor to at least meet all of you virtually. Unfortunately, with all the restrictions, we won't have the opportunity, but I think we're all pretty familiar with the virtual format. For those that don't know who I am or I haven't met, I started in this position as a division director of surgical oncology at the James in 2019. And although it's almost been 3 years, it seems like most of my time and my tenure here has been dealing with the pandemic. But I can tell you that one of the most exciting things and most enjoyable things is really working here at the James is to meet people like all of you who, without your support, we wouldn't be able to take care of the patients that we see daily at the James that deal with cancer. I think most of people, that when they think about surgical oncology, they think of surgeons that just cut tumors out every single day. Yes, that's a lot of what we do, but today I wanted to sort of highlight some of the other sort of interesting and amazing things that our team is doing for our cancer patients. Next slide, please. So our division of surgical oncology is one of the largest divisions, the divisions at the James. We have it broken down into disease sites, four sections specifically. We have breast, we have endocrine, we have gastrointestinal, and also melanoma sarcoma. In addition, we also have many faculty scientists that are working every day for coming up with the new discoveries in cancer treatments. I think one of the most fulfilling aspects of working here is actually being able to interact with friends and colleagues such as those in our division. We all say this, we all share the same goal as well, so to advance cancer care. As you can see, we are very diverse, a group of people coming from different places, different expertise. And I think most of you will recognize some of the names here. Dr. Farr, who's the CEO of the James. We also have Dr. Tim Pollack, who's the department chair of surgery at OSU. And of course, we have Dr. Rafe Pollack, who is the Cancer Center director. You can imagine having these giants of cancer surgery or even cancer medicine in general is something that gets used to. But I can tell you one of the reasons why I came here was because of these giants. I think most people have heard of this quote that you can see so much farther standing on the shoulder of these giants, and that truly has been an experience for me. Next slide, please. So I wanted to share a vision that we created in 2019 when I started. And the vision is quite simple. It's to provide an environment where passions and expertise in cancer care can develop and thrive. And I want to emphasize two words here, passions and expertise. As you can see from our division, we have broken it down into multiple disease sites because I think when you are immersed in a certain cancer types, then you really become an expert in what you do. And at the James, that's one of the things we strive for, to provide the world-class knowledge as well as experience for treating our patients' cancers. But also, you know, at an academic institution like Ohio State, you know, passions is actually very important. We're not just clinicians or surgeons, just, you know, taking care of patients. We came to, you know, Ohio State, to the James, because we have interest beyond just taking care of the individual patient. We have sort of desires to have impacts beyond, much greater than just operating every single day. Next slide, please. But the question is, you know, how do we nurture, you know, an environment in an arena where the playing field and the participants are changing? You know, when most people think of academic medicine, you think of the three pillars of education, clinical care, and research. That's what supports academic medicine. Unfortunately, with, you know, many of the changes in healthcare around the country, nationally, around the world, to tell you the truth, things are starting to change. Next slide, please. And I think one of the things that we've been seeing is that, you know, with education and research, that has been, you know, taken a sort of like a sidestep for us, or a side part for many of our day-to-day activities. Next slide, or next, can you click, please? To the point where many of our focuses of the surgeons and the physicians here at the James, you know, we're mostly focused on patient care. However, can you next click, please? However, we do know that without the support of education and research, which all of you have so graciously, you know, been involved in, you know, there's no way we can advance medicine. There's no way we can move the needle on cancer care. Next slide, please. So, as I mentioned earlier, clinical care delivery without research will not change the outcome of our patients. And I think one of the things that really drive me is my passion for research. You know, I think research is really a field of dreams. And this is a quote from Albert Einstein, where he says that logic will get you from A to B, but imagination will take you everywhere. And I think that's one of the things that many of the members of our division share in common. We're very curious. We're always, you know, thinking about, you know, the questions about how do we, how do we change the care delivered to our patients? What's the, you know, next discovery? What's the next treatment that we can do? And I think that's one of the things that, you know, that motivate us to work here at the James. Next slide, please. But, you know, I think we all run into, you know, obstacles. There's many different types of research. You've heard of, you know, basic research, lab research, translational human studies. There's also clinical research, epidemiologically, and also how do we implement all the discoveries into real practice in the community? Ultimately, this results in improved health. But one of the problems that we all face is that, you know, there's multiple silos. The silos are getting farther apart because, you know, the data, the information is becoming more sophisticated, more detailed. So, you know, we do very well in isolation, but I think one of the biggest impediments to the success of biomedical research and clinical medicine is the failure of each participant to see the value of each other. Next slide, please. So one of the visions for our division is surgical oncology, and I think, you know, at the James as well, is uniting researcher and clinicians in team science. So there's many things that we can offer for each other. So as clinicians, as cancer surgeons, we're able to know, you know, what do we clinicians need, because we're at the front line. We see the problems that our patients are facing, the ones that unanswered questions. But, you know, sometimes we need to ask, you know, what's available to help us. We may not be able to answer the questions that we see. Next slide, or next click. And similarly, there's amazing cancer, you know, research going on at the James. But for them, you know, for some of the scientists, you know, they may not know, you know, what's the best, you know, questions to ask, and, you know, what can, you know, how can the scientists help the clinicians as well? You know, being a scientist as well, you know, I spent, you know, a decade, you know, trying to cure, you know, cancer in mice, but how do we move it to the next level, the translation, bring it to our patients? And I think that's where team science comes in. Next slide, please. So tonight, I just wanted to highlight, I think, one solution that we have in our division, and that's the role of a surgeon scientist. So not only do we have amazing surgeons that take excellent clinical care, able to do technically challenging operations to remove tumors, but also then we have scientists, those that are actually asking the questions, analyzing, and coming up with solutions. I think the surgeon scientists are able to have their feet in both arenas, from the research stand and also the clinical. And I think that's one of the amazing things about some of the talented new members of our division that I want to highlight tonight. We have Doctors Joel Bean, Dr. Priya Dediya, Alex Kim, and Samilia Obengasi. So why don't we kick it off? And I wanted to start off with Dr. Joel Bean.
Thanks, Dr. Sung. I really appreciate everyone's attention for being here on an evening and hearing what our division is up to. We're really excited about the projects we're working on and the impact that it's going to have on our patients. Next slide, please. My name is Joel Bean. I'm an assistant professor in the Division of Surgical Oncology. I got my MD in general surgery residency at Indiana University and did more training at the University of Pittsburgh to learn how to take care of cancer patients. And I spent a short time at the National Cancer Institute studying immunotherapy and surgical oncology under my mentor, Steve Rosenberg. While there, I had the opportunity to work with him, and he pioneered a type of immunotherapy called tumor-infiltrating lymphocytes. And this treatment is shown up here on the left, and it's really been the driver of my research and my interests here at Ohio State. This treatment essentially involves the physical repopulation of the immune system with T cells that are derived from a patient's tumor. As you can see, these immune cells are harvested and purified from within a patient's tumor after it's been resected. And so hence the interest and involvement of surgeons. But this treatment, essentially, you take these T cells out, you grow them into large populations in the lab, and then you reinfuse them back into the patient, and they're able to induce durable tumor regression. And this treatment's different from other types of immunotherapy or chemotherapy because it's a living treatment. These are cells that we're giving. It's also different because it's a single dose that's administered. It's not given over a period of a year. It's a single dose, and more importantly, it's curative. You see objective response rates like this patient in the right, in up to 72% of patients treated, and 25% of patients like this gentleman go on to have a response of up to 10 years and beyond. Next slide, please. So, my real vision is to bring this life-saving curative therapy to our patients here at OSU. There are centers out on the coasts that do this routinely, but there aren't any investigator-initiated trials here at OSU. And not only is this going to provide a potentially curative cellular therapy for our patients, but it's also going to provide a platform for scientific discovery, as well as a foundation for more novel cellular immunotherapies. Next slide, please. And so why am I so passionate about this? It's because this therapy works. I mean, this is a CT scan taken from a patient that we treated at the National Cancer Institute when I was there. And you can see the big masses on the left side that are highlighted with these yellow arrows. And just after 14 months of a single dose of this living therapy, these tumors have vanished. And these are patients with a life expectancy on the order of months. So can we go to the next slide? This is another example of a patient with melanoma in a pattern of disease, what we call in-transit disease, where the melanoma tumor cells have been lodged within the skin and they grow uncontrollably. And these patients really don't have any other option when they come to us. And again, you see 12 weeks after a single infusion of this living therapy, essentially the patient's own immune cells have turned their cancer and their tumor into scars. And so, what we've done is we've written a protocol here. Next slide, please. To begin treating patients at Ohio State University. Next slide, please. And we've paired up with the Pelotonia Institute for Immuno-Oncology, who's going to help us really dive deeper into figuring out who can respond to this therapy, who's the best for this therapy, and how to better select patients for this therapy. Next slide. But there are challenges. Next slide, please. One of these is getting approval from the James leadership, which we've got. Next slide, please. The next is actually authoring the clinical trial and the protocol, which we've done. The next is developing a budget. And right now we're currently working on manufacturing feasibility and establishing an investigational new drug application. But these things take money. These cells have to be grown in a special laboratory with clinical grade reagents. Next slide. So while we're moving this forward, again, it's patients like this that we see whose lives are absolutely changed by a single infusion. Again, this is another patient treated at the NCI, and you can see the tumor response. Once you take care of patients like this, it's just life altering. And, you know, I've been working diligently for the last 2 years to bring this platform and this technology here to Ohio State, and we're making progress. I'm excited about that. And I can't wait to have our own pictures of success stories of patients here treated locally that I can hopefully share with you at a future event. So thanks again. This is my interest, and I look forward to collaborating with everyone in the future. Thanks again for your time tonight.
Thank you,
Dr.
Dr.
Happy to take questions here in a moment, I guess.
Yeah. Well, thanks, Dr. B. As you can see, this is a perfect example of team science partnering with the Pelotonio Immuno-Oncology Institute. And I'm pleased to say that, you know, one of the initiatives is to bring a cellular therapy program here to the James. Currently, many of the patients, they have to go to the NCI to develop these, you know, to get treated with these innovative techniques. But however, it would be our goal is to bring them here to Columbus, to Ohio, for our patients. So next, I want to introduce Dr. Priya Dediya.
Hi, thank you so much, Dr. Sung. I'm really excited to be talking to everybody today. I am an endocrine surgeon at Ohio State, and I've been here for a couple of years now. Before coming to Ohio State, I did my general surgery residency at the University of Michigan, and then I did my surgical oncology, so my endocrine surgery fellowship at the University of Wisconsin. While I was at Michigan, I learned how to develop organoid models, and that's been something that I've continued to be very interested in today. The reason that I came to the James and Ohio State was because this place, unlike so many other places, just has an amazing amount of resources, and not only resources, but people that really want to work with you to change the face of medicine today. And so I've been really excited to start some of the research that we've moved into. So next slide. One of the things that I've become interested in is adrenocortical carcinoma. One of the very first patients that I had as a surgeon at OSU was a patient with adrenocortical carcinoma. This is a very rare cancer. The adrenal cortex is a gland, it's part of a gland in the human body that produces cortisol. And adrenocortical carcinoma is a cancer of the adrenal cortex. This is a devastating cancer because only 6% of patients survive after developing this cancer and advanced forms of this cancer. Next. The treatment options that we have today are incredibly limited in their effectiveness. Next. And this is really in large part because there are very few models of adrenocortical carcinoma. So we really haven't had the ability to study the underlying mechanisms of disease of adrenocortical carcinoma. Next. Having a background in organoids, I was very interested to see if we were able to develop organoid models of adrenocortical carcinoma. So organoids are three-dimensional mini organs. They're very exciting because they're able to recapitulate features of that organ, and they have many different cell types. What's really important about them is that they can model human tissue. So this is a huge advantage over mouse models of disease. Next. The other thing is that they have many different cell types, and this is important in studying cancer because different cell types really affect the outcome of disease. Next. And what's very important for adrenocortical carcinoma specifically is that they can be generated from rare diseases, and they can also be generated from biopsies from patients who aren't even surgical candidates. Next. So we were interested to see if we were able to develop models of organoid models of adrenocortical carcinoma. So from that very first patient that I had with adrenocortical carcinoma, we were able to take their tumor specimen after surgery and we dissociated the tumor. So we created a cellular material that wasn't solid anymore. And then we were able to load these cells into a special kind of matrix that supported the cell, and it was three-dimensional in nature. We were then able to culture those for some time, and then we can look at the downstream production of those cells to see if they produce steroids like many adrenal tumors do. And then we're also able to do different types of studies, including looking at how these tumors respond to drug treatments. Next. So we're really excited to find that with our very first attempt at making these organoids, we were successful. So you can see a picture of these organoids in the green box there, and they're alive and then they grow over time. Next. But probably the most exciting part about making these organoids is that they really seem to correspond to patient disease. So the black bar represents a patient that had low cortisol production or a type of steroid. And then the red bar represents a patient that had much higher levels of cortisol production. And the organoids from those patients seem to reflect the type of disease that the patient has. Next. Also, when we looked at responses to different types of drugs, we saw that this really varied based on patients, and it seemed to reflect the patient disease as well. So this patient had a much better disease course and was responsive to drugs. And you can see that this patient's organoids responded to drugs too, where you have some significant decreases with different types of treatments. Next. On the other hand, another patient unfortunately had a very aggressive disease and had minimal responses to our traditional drugs. And this patient's organoids also had a very minimal response to all of these types of drugs as well. Next. So really the organoids that we're generating have responses that correlate to the patient disease. Next. So what we're really interested in doing now is to determine how the different types of cells that patients have, we can make these in the organoids, and we can identify the best types of treatments based on the different types of molecular mechanisms that are driving a patient's disease. So we can create organoids, identify the best types of treatments, and then eventually and treat these patients in the future in real time so that they can have the best outcome for their specific type of disease. So it's been really wonderful being a part of OSU and to be able to create this new, completely novel research model so that we can move the needle forward in treating adrenocortical carcinoma. Thank you so much.
Thank you, Dr. Dedia. You know, her work really is moving the needle on personalization of medicine. As you know, right now, you know, we get a biopsy to confirm cancer, and then patients are started with, you know, on chemotherapy, radiation, or just being operated on. However, we don't have a good idea of whether certain drugs, chemotherapy, or targeted therapies will actually work, because it's hard to replicate, you know, what's actually going on in a patient's, you know, tumor. But with the organoid research, you know, this allows for, you know, personalization, so we can test and identify the best treatments. So Dr. Dedia, with her expertise and partnership with biomedical engineering department, one of her sort of colleagues is actually heading the organoid sort of working group at the James, which is a bigger part of the new program, the cancer engineering program that Dr. Matt Ringo is directing. So next, I want to introduce Dr. Alex Kim. His work is in the area of sort of like my passion in gastrointestinal diseases. So Alex.
Thank you, Dr. Sung, and good evening, everybody, and thanks for joining us tonight for our event here. My name is Alex Kim. I'm one of the assistant professors within surgical oncology, and my main clinical focus is in management of GI cancers, particularly in patients that have advanced diseases or diseases that have already spread, which is essentially a paradigm shift within the field of surgery. Particularly approximately a decade or two ago, all these patients would be managed by medical oncologists, and we're not given a good, we're provided with grim prognosis and had no other options. But, you know, with our innovations, research, and our refusal to be defeated by cancer, you know, our field has come a long way. to share with you guys. I prepared some of the slides regarding some of our work here. If you could move on to the next slide. Just to give you an overview, colorectal cancer is a significant burden in our health system. We have approximately 150,000 patients that are diagnosed with this disease, and expected to have about 40,000 patients at the time of diagnosis to have advanced diseases. Currently in the United States, we have approximately 1.5 million patients that carry the diagnosis of colorectal cancer. And eventually, approximately 400,000 patients every year will eventually develop metastatic disease or cancers that have spread. And all these end up resulting in death for these patients. And we're expected approximately 53,000 patients to die. And majority of other patients live with morbidity of having the recurrent disease. Next slide. Particularly when we're looking at overall survival, it is clear that patients with distant disease have the worst 5-year prognosis, particularly for patients that have colorectal cancers that have spread within the belly cavity. When we were looking at approximately 20 years ago without any therapy, their prognosis or their survival was quoted at 6 to 8 months. Now, fast forward approximately 10 to 15 years with an advent of our recent GI chemotherapy, you have survival, reaching 16 months. And then within the most recent paradigm shift with an addition of surgery, where we're able to provide these patients with additional therapeutic options, now we're getting survival reaching all the way up to 41 months within the most recent trials. And these are significant. And essentially the goal becomes trying to convert a patient that have an acute prognosis of a poor prognosis to patients living with the disease, but able to survive for a long time. Next slide, please. Next slide, please. So one of the paradigm shift has been this concept of cancer regional therapy. This is a surgical principle where the key premise is that certain cancers may be confined to isolated compartments within the body, such as the lung, liver, or in my expertise, the peritoneum, or within the belly cavity. We know that, from our experiences for past 2 decades, that the surgical treatment specifically confined to these compartments where we were resecting the recurrent disease improves survival. And then we're also able to deliver anti-tumor agents without the added toxicity or the whole body toxicity that typically the patients would experience. Next slide, please. As such, the patients with peritoneal dissemination or cancers that have spread within the belly cavity are potential candidates for this paradigm shifting regional therapies. Next slide, please. The particular operation that we employ is called cytoreductive surgery, which is essentially surgical removal of all visible diseases within the belly cavity. Following that operation, it's a 2-part operation. Next slide. We end up instilling heated chemotherapy to clear any invisible diseases that may be left behind. With the advent of the systemic chemotherapy that have been optimized and also addition of surgical therapy, these patients are now, approaching median overall survival in 3.5 years or 41 months in modern times. Next slide, please. These are 2 of my patients that I operated on within my year of stay here at Ohio State. Patient number 1 and patient number 2 both are afflicted by what we call peritoneal carcinomatosis. The areas in the arrows are highlighting the region where there are a significant amount of tumor burden. The slides on the right-hand side is after the operation. Actually, these are surveillance scans that are 6 months out from the operation, and these patients are without any evidence of disease. So we know that we're shifting the paradigm. We're refusing to be defeated by the cancer, and we're helping these patients that otherwise would have grim prognosis. Next slide, please. Unfortunately, there are limitations and issues with the regional therapies that we employ. Next slide. Patients ultimately succumb to recurrent disease. Some of the patients have long survival, but they do have recurrent disease where we would have to, optimize their further chemotherapies or potentially, subject them to additional surgery. And this is a big operation where significant complication rates, all comers, whether it be simple wound infection, urinary tract infection, all the way to coronary events, it carries a 40 to 50% complication rates. So we have to do better. Next slide, please. So as a surgeon scientist, My role here at OSU is to develop what we call precision-guided cancer regional therapy. Next slide, please. Some of the works that we're handling in my particular lab is to look for utilization of novel biomarkers, whether it be DNA or genetic markers or other protein markers to predict response to therapy. Next slide. Or personally tailoring therapy, particularly the chemotherapy that will be instilled within the belly cavity based on patient-derived models. Next slide. Or identify unique therapeutic targets along their pathways that resulted in the recurrence of cancer. And ultimately, next slide, develop new drug delivery system or precision-guided therapy that would assist these patients to help their longevity beyond the 3.5-year time point that we have right now. Particularly in my lab, I just want to highlight that we are focusing currently on identification of unique therapeutic targets. Next slide, please. My lab actually looks at the mechanism that drives metastases. It is the metastases or the spread of the cancer that unfortunately result in poor prognosis in patients, and ultimately these patients succumb to their disease because of this process. So this has been the holy grail in terms of cancer biology, where we try to identify mechanisms that drive for this. And one particular pathway that my lab examines is a concept called the epithelial to mesenchymal transition. The colon cancer cells are normally static or they're dormant in their place. However, they hijack a normal developmental or a biologic process that already exists within the body, and they become motile. They become mobile, and they're able to gain functions to invade other places. Next slide. And particularly one of the things that we examine in my lab is a protein called TWIS1. This is a well-known marker of this phenomena, abbreviated as EMT. And currently what we're doing is to understand how this particular protein gets turned on in colorectal cancers, and particularly in patients that have metastases, but also understanding mechanisms and understanding ways to turn off this protein so that we could better help these patients. Thank you so much.
Thank you, Dr. Kim. I think that one of the things that he said at the very beginning of his talk, and I think that resonates true for all of the surgeons and researchers and in our division, as well as at the James, is that our goal is to offer hope. So as you can see from Dr. Kim's talk, we're dealing many times with patients with metastatic disease. And when you hear stage 4 metastatic disease, most patients are, thinking of, well, there's nothing else we can do. But that's not true. Not only with the sort of the expertise in surgery to be able to perform complex operation, but many of these innovative techniques that we can offer more hope in the setting of sort of advanced disease. Next, I want to introduce Dr. Samilia Obengasi.
So thank you very much for the opportunity to talk to you today. My name is Samilia Obengasi, and I'm a breast surgical oncologist here at The Ohio State University, and I'm also a health services researcher. My research focuses on social determinants of health and their implications for breast cancer. Next slide. Let's meet our fictional patient, Lisa. Lisa is a 36-year-old single mother of 1 who's just been diagnosed with breast cancer. Next. She lives in a neighborhood that's resource poor. What that means is that there are not very many opportunities for employment. The neighborhood has poor walkability. That describes the built environment. So the houses, the sidewalks, the architecture of the neighborhood is not one that's amenable to walking. And if she wanted to exercise, she wouldn't be able to do that. And also she has very few grocery stores in her neighborhood, and the neighborhood has been declared a health food desert. Next. She has a job in the community next to the one that she lives in, but it's a very stressful job, and she also has very little control over her work environment. Next. She has some money in her savings account. Her current income puts her above the federal poverty level, but unfortunately, if she is to face a very expensive life event, it'll be financially catastrophic for her. Next slide. So she has a limited social network. Her parents live in another state. Her siblings live in another city. She doesn't have very many friends at work, and she has even fewer friends at home. And when you ask her, she'll tell you she feels pretty socially isolated. Next slide. She's also about to discover that she's underinsured. So although her employer provides insurance for her, she's going to have to spend 10 to 20% of her income to cover the cost of copays, deductibles, and coinsurance from her cancer diagnosis. The things I just described to you are social determinants of health. So essentially, social determinants of health describe our living and our working conditions. Next slide. Next. Next again. So for breast cancer patients in particular, social determinants of health have been powerful influencers in terms of diagnosis, treatment, and also mortality from breast cancer. For example, women who live in neighborhoods that have a low socioeconomic status, or women who report social isolation, are more likely to present with advanced stages of cancer and also to have more aggressive types of breast cancer. Next. Additionally, women who are underinsured, government insured, or uninsured, or women who have financial instability that results in bankruptcy are also more likely to die from their cancer than women who were well insured or individuals who are financially solvent. Next slide. So my research question is, what is the mechanistic pathway from social determinants of health to cancer progression, initiation, and metastases, which is the spread of cancer? Essentially, my question is, how is the social environment that we live in, how does that become a part of our biology? Next slide. To understand this line of research, we have to understand the underlying hypotheses that help propel this research. Next. So let's have an imaginary scenario. Let's imagine that we're being chased by this monster on the left-hand side of our screen. Our body is going to go through a series of physiologic changes to help us get away from this monster, to help us escape. The first thing that's going to happen is that our heart rate is going to go up. Next. We're also going to have auditory exclusion, so our ears are going to help us focus a little bit more. Next. Our pupils are going to dilate, which is going to help us see a little bit better. Next. Our body is going to mobilize energy sources like fats and glucose. Next. And then our body is going to increase the blood supply to our muscles to help us run away from the monster. Next. What I described to you are a series of physiologic changes that occur in response to an acute stressor. In this particular example, we imagined we were being chased by a monster. For some people, this acute physiologic response can become chronic when they have a chronic monster in their life. As you can imagine, these physiologic changes can have significant implications for the development of disease. So individuals who face persistent stressors or stressful or challenging environments are more likely to develop diseases like hypertension, diabetes, obesity, insomnia, and also cancer secondary to these persistent stressors. What my research seeks to elucidate is how social determinants of health, like social isolation, workplace stress, financial instability, are perceived by our brain, which then result in a physiologic response, which then also can result in changes in gene expression and gene modification. So studies have shown that individuals who face a lot of social adversity, in addition to the physiologic changes I just described, also have changes in their gene expression. Specifically, people who face social isolation are more likely to have an increase in genes that express inflammatory markers. And as some of my colleagues have alluded to, inflammatory markers are important in the initiation of cancer. And they also have a repression or a downregulation of antiviral factors. This pattern of an increase in pro-inflammatory factors and a downregulation of viral factors has been observed in both healthy individuals who face adversity and non-healthy individuals who face adversity, telling us that the environment that we live in has significant implications for our biology. It is my hope that as my research better elucidates this pathway, that we're able to find targets that will be amenable to intervention. Next slide. So why did I choose to work at OSU? Next. Next. Is because my research is transdisciplinary. The type of research I described requires a team of academics with different levels of expertise. Specifically, my research here entails working with other surgeons, psychologists, individuals with expertise in bioinformatics, medical oncologists, radiologists, and biostatisticians, and a whole host of highly specialized individuals that bring different viewpoints to this type of work. Next slide. Thank you very much for your time. Here's my email if you have any additional questions, and also my Twitter handle if you want to follow me.
Thank you, Dr. Ogunjosi. As you can see, her work is so important since many of us think, okay, we see a patient we diagnosed with cancer and they leave our offices, but then what happens after that? I'm sure, every cancer patient is undergoing the stresses, not only themselves, but, and their families, their environment. And I think this is such a sort of like such important work that she's doing, trying to understand, how else can we help our patients that are coming to the James for treatment. It's more than just taking care of them clinically, but also helping them, with the environment and their own sort of psychosocial aspects that greatly affect their outcomes. So now I wanted to just ask our panel for specific questions, get their ideas, their thoughts on certain things. Why don't we start with Dr. Bean? It's very exciting, all your work, working with Zihai Li, the Pelotoni Institute for Immuno-Oncology. Can you describe to us more how you collaborate with them?
Yeah, no, thanks, Alan. I think it's a great question. I think if we're going to extend our footprint as surgeons beyond Columbus and make an impact on patients around the state, around the US, and around the world, it's going to be in the lab, because as surgeons, we can only take care of so many patients on a day-to-day basis. In addition, we're all a little crazy and type A personality, and, we're not satisfied with partial responses or anything less than a cure. And so this is where our partnership with the PIIO really comes in. It's not enough just to treat the patients. We need to dig deeper and ask why and ask how. And this is where that partnership comes in. It takes infrastructure to ask those questions. It takes technology. It takes motivated, highly trained scientists to dig deeper and to formulate the readouts that we need to ask the broader questions, such as, why isn't the response rate 100%? Why aren't we curing everybody? And that's the goal. And it takes the support of the entire community, not just the treating physician, but also the lab team. And that's the void that they really fill, and really help move things on to the next level and develop that next question that we can address clinically.
Thank you. As you can see, there's a common theme or a thread, throughout all the presentations, is being able to work with others, the importance of team science. On that note, Dr. Dedia, can you talk to us more about your partnership with Nationwide Children's?
Yeah, so that's a very wonderful partnership that I have with Dr. Elaine Martis, who is a scientist who really started the field of cancer genomics. So I'm lucky to be able to partner and collaborate with her on some of the work that I do in order to look at the genomics of organoids. So I'm interested in doing this with primary patient samples, but also with our organoids, so that we can really understand how the disease is progressing, and then in the future, how we can stop the disease from progressing. So it's an exceptional way for us to partner together and really use different types of technology to address a common goal, and come together to learn a new way of doing science. So it's kind of been a mutual relationship also, in terms of I'm learning how to do some of these techniques that I haven't been exposed to doing before. But on top of that, Dr. Martis, a lot of her work has really focused on identifying the markers, but really not having a way to functionally test if these markers are relevant in patient disease. And so with our organoid models, we can actually test and manipulate those markers to see if they're important the way that we think that they might be from some of the work that she's doing. So it's been a fantastic partnership for me.
Thanks. You can see we're breaking down the silos, not only from the different specialties, but also just physical separation. And it's great to see collaboration from multiple campuses together. So next, for Dr. Kim, you work with advanced stage cancers. And I think as surgeons, all of us, are very type A, and we want an answer. We want to see the results of our work almost immediately. Can you tell us, how your work is improving outcomes for our patients?
Sorry, I think I was muted there for a second. So thanks for that question. Particularly dealing with metastatic disease or patients with advanced cancers, it's our refusal to be defeated by cancer itself. And we have come a long way in the last 2 decades. You know, within the slides that I shared with you guys, you know, 20 years ago, these patients would have been, you know, quoted with a survival rate of 6 to 8 months. And now we're up to, you know, 3.5 years with the advent of what we call regional therapies or cytoreductive surgery and HIPEC. But unfortunately, that's just not good enough. The reason is this. You know, even though we've done a really wonderful job in preventing cancers from spreading in older generations, what we're seeing now is younger and younger patients that are, you know, succumbing to colorectal cancers. Hence, last year, you know, the WHO, as well as American College of Surgeons, in conjunction with American Cancer Society, recommended for preventative colonoscopy to be moved up to age 45. So when you look at patients that have colon cancer diagnosis with a spread within the belly cavity at age 25, 3.5 years of survival is just not enough, and it should not be accepted. So the work that we're doing in my lab, particularly examining the way the cancer spread, particularly breaking down the mechanism, identifying the targets so that we could go after these targets. You know, I'm hoping that, you know, we're providing hope, but also therapeutic benefits to the patients that otherwise will not have any other options.
Thanks. It's just providing hope, like we talked about. And then finally, Dr. Obengesi, your work on social determinants of health have really opened up like new avenues of research. But can you talk to us more about, you know, how you're combating, you know, clinical disparities in your field?
So we just had a wonderful project funded by Pelotonia that looks at a subset of breast cancer patients that suffer from triple negative breast cancer, but unfortunately die within 24 months of diagnosis. And so in this particular project, we are combining our understanding of social determinants of health to create a screening tool to identify these patients when they first come to our clinics. And then one of my collaborators, Dr. Anderson, is a psychologist who has created a biobehavioral stress reduction program. This program has been used in the past among breast cancer patients and has been shown to improve survival and also reduce recurrence. So what we're doing is we're incorporating elements that address social determinants of health to try to help this subset of patients that have such an aggressive cancer and such a poor outcome to see if we can mitigate some of the poor outcomes that they're facing. And I should mention that study also includes a medical oncologist, Dr. Stover, and a guy with bioinformatics, Dr. Rancor. So as I mentioned, my work is very transdisciplinary.
Right. Well, thank you, team, for all your time, the important information you shared. And I do want to highlight that all four of these surgeon scientists, their work would not be possible without the support of the James Pelotonia Institute, supporters like the James Ambassador Society. So we really do appreciate, your contributions and your support for the work, not only in our division, but also at the James. You've armed our ambassadors with a lot of information to share within their networks. Now I just want to open up the meeting for questions from the audience. If you have any questions, please use the Q&A feature at the bottom of the screen. If we don't get to your question due to timing, we're happy to follow up post-event. Oh, there's one question from the chat is, how has philanthropy impacted your work?
Oh, I can go. We also received a Pelotonia grant this past fall, and it allowed me to hire another person in the lab, which has significantly helped in moving this trial forward. It's busy as a surgeon and it's tough, and this person is highly motivated and wants to see the type of change that I want to see, and her being a part of the team wouldn't have been possible without those funds. And so, I mean, that's a huge help. Supplying the reagents, again, the cellular therapy is very expensive to do, and it's allowed us to pay for the reagents, the media. They have to be grown in special flasks, so it's allowed us to purchase those flasks, and all of these funds will be going towards generating preliminary data for an investigational new drug application with the FDA to move this clinical trial forward here for patients treated here at OSU. So huge impact.
I mean, I can echo that as well, not only for the research support for my own research, but philanthropy has been instrumental for supporting innovative sort of clinical programs. One of the things that we just started a few months ago at the James is a pancreas cancer multidisciplinary clinic. So where all newly diagnosed pancreatic cancer patients can come one day, see it's a one-stop shop, seeing the surgeon, the medical oncologist, radiation oncologist, we all meet. So at the end of the day, they'll be able to get an answer. What's the treatment path for them? And this is sounds easy enough, but unfortunately, it's very difficult to do with a traditional model where you see a physician, say you see a surgeon, and then you have to make an appointment to see the chemo doctor, and then you make another appointment to see the radiation oncology doctor. So that's a delay in the diagnosis as well as treatment. But for this medical or for this pancreatic cancer multidisciplinary clinic, we can get the answers in one day. And in order to support that, we needed a nurse navigator, a patient navigator, where it can gather all the information, where it can coordinate all this. So philanthropy has been instrumental in being able to support this program, the unique program, not only at the James, but in Ohio. Here's another question. What do you think is different in the care at the James?
I could answer that question. I think at the James, it's a unique environment. This is a place where innovation is treasured and it's pushed. And also in terms of cancer care, it's always focused on multidisciplinary with the patient in the center. So to bring in terms of the clinical care that I particularly provide, it's been a nurturing and fostering environment, but also allow for us to innovate within our disease site so that, our outcomes for our patients could improve.
The other thing too is really the Buckeye spirit. I mean, I'm kind of a sucker for these kind of things. And it was one of the things that captured me on my interview here with regards to, how willing to help people were, and people, genuinely care. You're just not another cog in the wheel. You're just not another patient in the cancer factory. I mean, you have a name, and, and this is from everybody when you meet the door all the way up until whenever you leave. And it's something that really impacted me about the way that care is delivered here. It just seems so much more humane and humanistic to me. And that was one of the things that drew me to Ohio State for sure.
I think we have time for one more question. Another question in the chat is, how has the pandemic impacted your surgery schedule, if at all? You can see it's affected all of our lives, even with this event here being virtual. I know for endocrine and breast, for doctors Dedia and Obajesi, their schedules were significantly impacted. Can you share a little bit about that?
So for breast cancer, unfortunately, a lot of patients, based on the pandemic and sort of difficulty coming into access resources, chose to forego their mammograms. And so as a result of that, we're facing a backlog of patients that are coming in now, which is appropriate because they couldn't go last year, that are having much more aggressive cancers than we would have seen had they been able to have access to mammography earlier. So I think the pandemic has had significant implications for our patients, and specifically for patients who prior to the pandemic were facing barriers in access and care, might be having some more issues since the pandemic.
And it's actually very similar for endocrine cancers as well, where several patients were not getting appropriate follow-up. They may have noticed a mass in their neck, but because of the pandemic, they didn't see their physician. And so evaluation and therefore surgery was delayed. And that's a really important aspect, because for thyroid cancer, even though it doesn't always lead to mortality, it actually leads to a very large impact on financial stability. So those patients, even more so than patients that have more aggressive diseases, have loss of financial stability. So our ability to, or the delay in care can really impact how these patients end up doing long-term from a financial standpoint. So that has been one impact. And then another impact is that more recently as well, patients have again been testing positive for COVID. So this is difficult because of all of the changing guidelines. It's challenging to really find, to be able to deliver care in a very fast manner that we usually like to do. And so we have to kind of change around our schedules and then try to find time to fit these patients in that have been tested positive right before surgery as well.
I think we have time for one short question. T-cell therapy is so promising. What forms of cancer is this form of treatment currently being pursued? That's probably for Dr. Bean.
Yeah, Paula Bros, thank you so much for the great question. It's in phase 3 clinical trials right now for lung cancer, melanoma, and HPV positive cervical cancer. The issue with these trials is that they're industry-sponsored trials, so we don't have access to any of the tissue, and we're really limited with regards to what we can study and what we can address. The trial that I proposed tonight is an investigator-initiated study that we're wanting to open, and it's really a open histology trial where we're trying to open this trial for patients with really any cancer who have failed systemic therapies and conventional therapies. And so the details of that are still being worked out. But it's something we hope to be able to offer to everyone.
Well, I want to be respectful for everyone's time. Thank you for spending your evening with us, and to my colleagues for providing us with new and exciting information to share within our networks. We hope everything you have learned this evening has given you a better understanding of how the Division of Surgical Oncology operates, who we are, and what sets our program and hospital apart from the rest. Thank you for continuing to stay informed. Stay well and take care.